Alrighty, I think it's the time to start our first talk. We're going to learn about headaches from a pro today. Many of you know Dr. Lucas, who is a clinical professor of neurology, neurological surgery, and rehabilitation medicine, and she's also a director of the world's best headache clinic. She has been a true husky. She's done a lot of her education here at the U. Then she left us for New York for a while, where she did her residency at Cornell, and then she came back and has been here ever since. Those of you who know Dr. Lucas, she's a phenomenal clinician and a great teacher and a very prolific writer. She published a lot in the subject of headache. She recently is focusing on post-traumatic headaches and has some nice publications on that. She lectures extensively, and she really lectures well, and you'll witness this in a few minutes. When she is not lecturing, she works with television. She was featured on PBS, so I highly recommend you that you watch this piece. And when she's not clinically busy, she's typically chasing penguins in Antarctica, so you can also talk to her about this. So without further delay, Dr. Lucas.
Thank you. That's a great introduction, and I promise I don't have one penguin flying in here. As Dr. Margolis said, this is on headaches, so if you don't learn about it, you will get one. Chronic daily headache disorders are not terribly common, but I think that they're the type of headaches that a lot of us will see as either general neurologists or specialists, and they're the ones that are over on the right, about 4 to 5% of the population. Most primary care people are going to see migraine. About 35 million people in the United States now complain of migraine or have migraine, but about half of them are not diagnosed. So this is all done in epidemiologic questionnaires type studies. I'm not going to talk about episodic ho-hum tension type headaches, which has a 1-year prevalence of about 40%, lifetime prevalence of about 96%. In this arena of chronic daily headache, I want to talk about this because I think migraine is actually, now once you understand it and you can diagnose it, episodic migraine is relatively easy to treat. But what I want to talk about now is the stuff that, the people usually see have been to 12 doctors, they usually have comorbid conditions, they're not very happy, and they're very, very time intensive. Again, not a big money-making proposition, but I want to tell you a little bit about them. So in the category of best actor for a chronic daily main feature, we have transformed migraine, chronic tension type headache that, again, I'm not going to talk very much about, new daily persistent headache, and hemicrania continua. Now, any one of these can be with medication overuse or without medication overuse, and I'm going to talk about that a lot in a little while. So remember, really the definition of chronic daily headache is really a daily or near daily headache. So a headache that's at least 15 or more days a month, more than 4 hours a day. Prevalence, as I said, is between 4 and 5%. And the annual incidence of episodic migraine that becomes chronic migraine is about 2.5%. It's also a very fluid diagnosis. So, for example, 57% of chronic migraine will revert to episodic migraine over about a year. If you wait over 2 years, it's about 66%. There's been some really very interesting epidemiologic studies looking at what does it take for migraineurs to become chronic migraineurs. And Ann Shear was responsible for a lot of this data. And looking at a lot of different risk factors, she found that the tightest risk for an episodic migraineur becoming a chronic migraineur was obesity. And after that, there's other factors such as, I love that, previous marriage. Should be 60% of people are going to have chronic migraine. Diabetes, arthritis, ethnicity, education, play a part in this. Top quartile of caffeine use, which I feel is why our headache clinic is so popular in Seattle. Stressful life events in the previous year, snoring, high baseline frequency of migraine, and of course medication overuse. In the breakdown of chronic daily headache, Steve Silverstein has done a really nice job also with epidemiology. Most of the people you see with 15 or more days of headache a month are going to be transformed migraine or chronic migraine. A few are going to be chronic tension type headaches, and the other is going to be a smattering of hemicrania continua and new daily persistent headache. Now, in Spain, Castillo et al., that's a headache group in Madrid, looked at two populations. One was in a general population and one was in a headache clinic. And again, for chronic daily headache, as far as in both populations, you've got about between 4 and 5%. But they found in their general population that almost half were chronic tension type headache, about half was transformed migraine, and new daily persistent headache and hemicrania continua very small. But in their headache center populations, as in ours, the transformed migraine is going to be 80%. And in Silverstein's pie in the slide before, you saw it was about 78%. And when you see these chronic daily headache patients, about 80 to 90% of them are going to be medication overuse. Chronic daily headache is pretty much the same in the U.S. as it is in the rest of the world. Here's just a population study. Most of these are case studies, and it's not there are some differences in the case definitions and the type of patients they took. But if you look at the totals, I think Ann Scher's study is the best, and she's got about 4%. The next four slides are going to be definition slides. Transformed migraine is not an international classification of headache disorders type of migraine. It is a description. It's a chronic daily headache that develops gradually instead of precipitously. Typically, people have to have a prior history of migraine. There has to be a period of escalating headache frequency, and sometimes concurrent superimposed very severe headaches. So you'll get someone perhaps that comes in and said, I have a 7/10, 20 days out of the month, or you'll see that on their headache diary, and then there'll be a couple of days when they're just in bed with a 10/10. There are, however, international classification of headache disorder criteria for chronic migraine. This is really a work in progress. It's difficult to get a lot of people around the world and have them agree on something. It's difficult in the United States in Congress. So I think that this is something that may evolve over time. So you're looking at chronic migraine. You already know that for the word chronic to be in front of it, it's got to be 15 days or more a month. And it occurs in a migraine patient. So you've got 15 days a month, but at least 8 of those days, or roughly a week, a little more, have to be migraine. People have to meet the criteria of migraine, and or they have to have taken a triptan or an ergot and their headache responded to it, and it can't be medication overuse headache, because that's going to have its own definition. The next 2 slides are going to be about headaches that I'm not really going to talk about, but I want to tell you about them because I think that if you work in a headache clinic or if you work in a neurology clinic, you're going to see this. And these are really difficult people to deal with. New daily persistent headache is a headache that's daily and unremitting from almost the moment of onset. So people will usually say, my headache started November 13th, 2011, and it's still going on. So they'll really be able to nail the date on it. And it takes either 2 forms. It's one that's self-limiting, so it may go away without therapy or with therapy in a few months. And there's another that's very aggressive and resistant to treatment. So for example, I had an 18-year-old woman from Juneau come down with new daily persistent headache that had been going on, I think, 8 months. And she'd been on the usual preventative medications that I will list in a while. But she was really refractory. I could get her a little bit more comfortable with a low dose of fluoxetine and chlorpromazine at night, but otherwise she wouldn't respond to anything you typically think of for headache. But going back and just taking a hard look at her history, she had Hashimoto's thyroiditis diagnosed about the same month, and as time went on, she got better as her thyroid function got better. So was that related? It's not anything I can prove, but if you go back and look at some case series of new daily persistent headaches, about 30% may have their headache in onset about the time they get a flu-like illness. Hemicrania continua. This is great. I think this is underdiagnosed a lot. This is a strictly unilateral headache, and it just waxes and wanes in intensity, but it's always there. And usually when the intensity gets really, really bad, you've got concurrent autonomic symptoms. So you'll get the same thing you might expect with cluster or some migraine. You might get a red eye, a droopy eye, congestion, something like that. But part of the definition of hemicrania continua is that it is an indomethacin responsive headache. That it has to respond to that, and only then can you diagnose that. Of course, by that time your stomach is going to be ripped up to shreds too. But if you can get people to take it for 48 hours, that's about the time you need to be on indomethacin for response. So what about the timing of chronic daily headache phenotypes? Well, interestingly enough, most of the people that you will see with chronic daily headache, again, half of the month, 50% of the month or more, are going to have frequent headache. What does that mean? Well, that's 15 days of headache, 16, 17, 18, 19, 20. About 15% of them will have headaches every single day, but about 17% will have continuous headache. There is no break. So they wake up in the middle of the night to go to the bathroom, they're going to have a headache. It's going to be no relief. So, as I said before, about 80% of the people in our clinic, or the clinic we see, have medication overuse headache if they're chronic daily headache patients. And this is the ICHD criteria that was revised in 2006. So what's important about this? Well, again, chronic daily headache, so they have to have about 50% of the month in headache, 15 days of headache or more. And they have to have overused medication. Does this mean you can't diagnose medication overuse if it hasn't been 3 months? No, not really. But I bet on average you're going to see people who have been on daily or near daily medication for 3 months minimum. It's probably going to be more like 3 years. So you're going to see a lot of people. I think the person that was on, I saw on Fioricet the longest, had been on it for 52 years. So, you know, and she had medication overuse. But at that point, we can talk about her later. But you can diagnose it a couple of ways. First of all, if someone is overusing a single drug, let's say it's Cafergot or Imitrex or Vicodin, if they're taking any one of these drugs 10 or more days a month, then they are in the running for medication overuse headache. It's possible. Now, if you combine analgesics, so simple analgesics, let's say they're just on Tylenol, or Tylenol and Imitrex, or Tylenol, Imitrex, and maybe they pop a few Vicodin afterwards. If they're on combination more than 15 days a month, then they're in the running for medication overuse headache. It might take less than that, it might take more than that, but this is, you know, kind of a conglomeration of what everyone's patients, when you look at headache diaries and what people use, are coming up with. And this is key. They're not going to do that overnight. It takes a while to develop medication overuse headache. And if you really sit there and drag it out of them, you can kind of have a parallel course of escalating headache, escalating medication use. You cannot make the diagnosis of medication overuse headache until they're off the offending medication and they go back to normal. So until then, it's possible medication overuse headache. The other thing that I think that these definitions don't do for us is I think people can have a number of problems. For example, let's say I'm seeing someone who has breast cancer diagnosis and she's on Femara or In the old days, it was tamoxifen. And now we have transplant people that are on some of these anti-rejection drugs. There's a significant percentage of people that get daily headaches from these. But then they take Vicodin on top of that. So is it the drug? Is it the combination? But you really can't tell until you take them off what you think the medication overuse headache is, and then try to figure it out from there. We used to call it rebound. You can still call it rebound. But it's not that someone's going to have a new headache. You have to have had a headache before in order to get this daily escalating headache. If you want to nip it in the bud, no matter what you give people, and I don't care if it's an Imitrex prescription or you're giving a little Vicodin for someone else, you make sure that they know that if they use it more often than 2 to 3 days a week on average, they're at risk for having their headaches become worse. And our problem, as many of you have discovered, is that if people are in medication overuse, then your acute therapies won't work and your preventative therapies won't work. You have to get off the medication. I think that there is a risk profile of a drug to be an overused drug, and I think it probably has to do with the half-life of the drug. When I look at the drugs that are the worst offenders in terms of being an overused medication, it really has to do with the drug half-lives. So if you're looking at medications that have a high risk of rebound, anything that contains caffeine can do it. Actually, just caffeine on its own can do it. And things never cease to amaze me, but I found another woman that was drinking 10 cups of coffee a day, which, in itself is going to have a withdrawal effect. So, you're going to take medications because you're withdrawing from coffee. It just tends to be a mixed bag. Short-acting opioids, nasal decongestants, Afrin is a big one. Again, these sympathomimetic amines are pretty potent vasoconstrictors, short half-lives. Benzodiazepines used to be worse in the old days when Halcyon was kind of the #1 sleeper, because a lot of people would get headaches from that. And ibuprofen, believe it or not, is really a big one for medication overuse. The moderate to lower risk are the longer half-life drugs. So DHE, a drug that has a half-life of 10 to 14 hours, versus Imitrex, that's about 4 hours, less chance of rebound. Long-acting NSAIDs. Unfortunately, Vioxx, my favorite drug, is no longer with us. Simple analgesics, plain aspirin or Tylenol, it's not impossible, but they're not as likely. The long-acting opioids are better, triptans are better, and naproxen has less of a chance of causing rebound than ibuprofen. Guidelines for initiating prevention. So you have someone who has frequent headache. These preventatives aren't just for people that have chronic daily headache, and in fact, there is only one medication approved by the FDA for treatment of chronic migraine, and that is onabotulinum toxin A. So the others are preventatives, but again, the indication then is for chronic migraine or chronic daily headache, but it's not a specific indication per se. I think that if you are treating frequent headache or if you're treating chronic daily headache, we don't have any information, in other words, that will say this drug is better for a frequent headache versus a chronic daily headache. But I think we try these because we want to get people, back on track with their lives, and some people can't take acute therapy anyway. So there's a lot of different reasons to use preventatives. This is a case of someone I had a few years ago, a 38-year-old woman. She had a long history of episodic migraine. The headaches gradually increased in frequency, and it really kind of increased in association with her Excedrin migraine use. But what was interesting about this, and another point I want to make about potential rebound, is initially she was getting relief from 2 tablets every 6 hours, then every 5 hours, now every 4 hours. So when people get rebound, the effective half-life of a drug will get less. So somebody might say to you, Vicodin took care of my pain for 8 hours, but now I have to take it every 6 hours. Now I have to take it every 4 hours. So there is this half-life change as well, or effective half-life change. During pregnancy, she switched to Excedrin tension, that just doesn't have aspirin in it. And now she combines that, and she also takes Excedrin PM to sleep. which is basically Tylenol and an antihistamine. And she rescues with Fiorinol or Fioricet, or like more caffeine in there. Butalbital, aspirin and caffeine for Fiorinol, butalbital, acetaminophen, and caffeine for Fioricet. So she's waking up with a headache every day. It's about a 3/10, and if she doesn't take 2 Excedrin, then the headache will get worse and become very severe. And that's one of the pearls of rebound headache. If you know the answer when you ask it. You can say, are you waking up with a headache every day? And they'll say yes. So they either wake up with a headache or they get it within 2 hours after they get up. Because what they took the night before has worn off. So it's almost like a withdrawal phenomenon. And usually another thing is they're always complaining of neck pain or occipital pain with these rebound headaches, and I still don't know why. The problem with this patient, as this case, and I'm just going to tell you about the case, I'm not going to tell you what we did, you can imagine what we did, but it interfered with her life and nothing worked. So sumatriptan didn't work, nothing but Excedrin migraine worked. So again, it illustrates the problem that migraine-specific acute therapy and preventative therapy will not work. So what she had to do was discontinue the Excedrin, and there's a couple of ways to do this. And I will say that we're all guilty. At least the doctor that gave her the Fiorinol or the Fioricet. I've only had 3 patients end up in an ICU from GI bleed. They've all done it with Excedrin migraine, and that's the other thing. Sometimes you can't trust what people tell you. You can lead a horse to water, you can't make it drink. So sometimes I think in retrospect, I thought, now maybe I'll just run a quick hematocrit on people who seem to overuse Excedrin. And how do we wean off overused drugs? I just want to bring up 4 general ways we have to do it. And I've got lots of slides and paperwork and papers I can give you, including sort of an inpatient hospital protocol if you are interested in having it. Conventional outpatient, you can do it fast or you can do it slow, depending on, if you think the patient will be able to do it. A slow wean, basically you would say, all right, so you're on 8 Fiorinol a week. Why don't we just drop 2 every week until you're off? So you figure out some sort of taper schedule. That seems to work better with things that have barbiturates in them or opioids. And simultaneously, you can add a preventative medication. So you can add, and they won't work in the beginning because if someone's in medication overuse, they won't work. We call that bridging therapy. You're sort of putting them on something, it's not going to work in the beginning. It's not going to work until you get them off the drug. You just have to have faith that it's going to work. Onabotulinum toxin, again, the FDA has approved it for chronic migraine. Interestingly, if you're writing a prior auth letter for Botox, botulinum toxin, the FDA just looks at chronic migraine as 15 days of headache a month. They don't want to know if you have medication overuse. They don't want to know if it's new daily persistent headache. It's just CM. So that makes it a little bit easier. You can also do a quick discontinuation. So that's cold turkey. And I don't mind having people do that if they're on a Tylenol or a combination simple analgesic or Excedrin. I think that's probably pretty safe. And you do the same thing. You can do a bridging if you want. Sometimes if I think that the patient has a good chance, depending on what their headaches were like before medication overuse, if you think that patient is going to be really good without putting them on preventative therapy and just taking them off their 10 Excedrin a day, don't just take them off. And if they can stand it, maybe with some bridging therapy with sumatriptan every day for 5 days or naproxen sodium BID for 5 days, you could also do that as well. Then a couple of infusion models. One of the things we can do is use infusions as a bridge. So we have a nice infusion center on 8 Southeast that we sometimes have access to. So if someone has refractory or medication overuse headache, we can bring them in every morning for 5 days and give them 1 milligram of IV DHE and perhaps rehydrate them and perhaps some IV Toradol, and then start them on medications, bridging preventative medications. And that's a nice way to start getting people off overused medication. or the Cadillac and gold standard of weaning or dealing with refractory headaches is a multidisciplinary program. Now this can be in a day hospital like the IMATCH program at the Cleveland Clinic. It can be an inpatient program that we used to have at Swedish Hospital, where people would come in and you'd immediately have a multidisciplinary team. You'd have a nutritionist, you'd have a psychologist, you'd have a physical therapist, you'd have a biofeedback person. So you just kind of come in and you're set up for all that. Then you also get your every 8 hours IV DHE and whatever else is part of that program tailored to the individual. And again, add preventative medications or any bridging therapy that you need. Goals of preventative treatment are obviously to reduce attack frequency, severity, and duration. But many people will tell you that, let's say they were taking Imitrex or Maxalt or something like that, and sometimes putting people on preventatives improves the way they respond to their acute therapy, and it's really interesting. And I don't exactly know why that is, but I hear it enough. It also reduces their acute medication, which you really would like to get at, and some people will feel that a migraine is a progressive disease. And again, we have a feeling of this going from episodic to chronic migraine. It's still very debatable. There's a really nice couple of papers that were published in Neurology about 3 or 4 months ago. I think the first author is Steve Silverstein, and it's kind of nice to have these in your back pocket. They're actually the evidence-based results of your preventative therapies, and they're listed in terms of how good the clinical trials were, of course, that they were involved in. So your level A drugs greater than or equal to 2 class 1 trials. So a nice placebo-controlled double-blind trial that was powered effectively to show a result. And the AEDs were divalproex or sodium valproate and topiramate for AEDs. Beta blockers were propranolol that's just made the list. Metoprolol that's just made the list, propranolol that's been there for a while, and timolol, which not very many of us use, but is usually very cheap and on most formularies. And the triptans have also been approved for menstrual-related migraine or menstrual-associated migraine. So there's a really nice study using frovatriptan, also known as Frova. It comes in 2.5 milligrams. And for the 60% of women migraineurs that have menstrual-associated migraines, so you can pretty much guarantee a headache, 1 or 2 days before to 3 days after the onset of the menstrual period, which is thought to be an estrogen withdrawal type headache. If you do Frova BID 1 day before to 3 days after, that really kind of works for that headache. So if people aren't doing really well with their usual migraine therapy, then use that as a preventative. Level B efficacy, amitriptyline, venlafaxine for antidepressants, the beta blockers, the atenolol and nadolol made this list, and 2 other triptans, naratriptan or Emerge and zolmitriptan or Zomig, were approved for menstrual-related migraine here. Level C, possibly effective, lisinopril, candesartan, clonidine, I don't know the other one, carbamazepine, some of the beta blockers, and ciproheptadine. And ciproheptadine, interestingly, it's an interesting antihistamine. It's got 5-HT2 antagonist properties, kind of like a stop signal for migraine, and it is used very frequently in the pediatric population as a preventative. Very sedating, however. Inadequate data or conflicting data. Now, we use these drugs, but we don't use them for chronic migraine. So, for example, you've got no good data that acetazolamide is really going to help in chronic migraine, but obviously in headaches associated with pseudotumor it may work. Coumadin, no data that I've seen that it really helps in any kind of headache. Sorry about the misspelling. Fluoxetine is an antidepressant. There was some data coming out of Joel Saper's group in Michigan that fluoxetine might help for chronic migraine, but it was a very small, underpowered study. Gabapentin, not terribly useful for migraine, even though it's a good pain blocker. And And again, the calcium channel blockers have not helped in chronic migraine, though we find Rapamil of very big help as an add-on drug in treating cluster headaches. Here, the second article then that backed up to the first article was about class evidence for NSAIDs and complementary therapies. And Butterbur is the only drug that has level A evidence. And these are all over the counter. You can find them in supplement stores or upper scale grocery markets like Met Market. Some of the NSAIDs, magnesium fever-free riboflavin, a level C possibly effective, flurbiprofen, which I find actually really good, but not for moderate to severe headaches. It works pretty good for mild to moderate headaches. And then again, aspirin, indomethacin, hyperbaric oxygen, not really good for as preventatives, although once again, indomethacin is great for the indomethacin responsive headaches of hemicrania continua or paroxysmal hemicrania.
Sylvia, can I ask you a question?
Yeah.
Do you think that there are some people who are completely resistant to developing overuse, medication overuse headaches?
Probably.
Probably.
Yeah.
I mean, I can't imagine that we all haven't seen an occasional patient with osteoarthritis who's been on a regimen of some kind of analgesic for years with no complaint of headache whatsoever. I'm wondering, that begs the question, is there anything in your mind that that sets the stage for this?
Well, I think it's a question that gets back to one of the criteria that person would have to have migraine in the first place. So you've narrowed that down to about 18% of women, for example. And then osteoarthritis, I mean, some of these pain conditions tend to come when you're in an older age. So maybe if you're treating RA in a 20-year-old with migraine, you might be more susceptible to get that than osteo in a 60-year-old maybe who's postmenopausal and the headaches are really not a big issue anymore. But I think even with that, having said that, I've seen people on Vicodin every day for something, they won't get it. So yeah, I mean, I think there's things that that genetically that predispose people to medication overuse headache. We just don't know what they are yet. That's a good point. I think the biggest single reason people fail their preventatives is we don't give them an adequate trial, or we jack up the dose too much so they get the side effects and don't get the adequate trial. So for example, topiramate, a lot of times we'll go 25, 50, 75, 100, but 75 and 100 milligrams were the median doses in the clinical trial for that in migraine. But I have people that respond very nicely with 25 milligrams. So you don't have to increase it really fast. You can just say, just stay on this for a couple of weeks, or even take it slower. Do the kids dose, the 15 milligrams. So I think you see again, and this is getting back to what I mean about chronic daily headache people taking up a lot of your time. If they don't get back to you, they need to get back to your nurse. They need to get back to your email. But you're always trying to see. Do you take the next step? Are you having side effects? Do we need to change? So it's a conversation. The biggest problem you're going to have with evaluation is that if there is drug overuse, if they're still taking daily medications, again, if you're using it as bridge therapy, it's not going to work. So you're going to have a problem there. The best thing that I have found that helps me in my practice is for people to use a calendar, because they can just come in, you can add up the days, you can look at the average intensity and see if you're making some progress. Because a lot of people will not remember, they just can't remember, and if it's a gradual decrease. If you're going to use onabotulinum toxin, now most of the companies like Regents are really requiring a patient to keep a headache diary. So you either have to document it or fax it and send it to them. So it's always nice, and we've got plenty of headache diaries. If you need one in our clinic, we'll just send it to you. Family planning issues. if people say they want to start a family, you're probably not going to give them Depakote or topiramate, and still 60% of pregnancies are unplanned. And topiramate has now made Class D FDA rating scale as well as Depakote. So besides evidence-based medicine, there's a lot of other things that you're going to think about before you recommend preventative therapies to people. Part of it is going to be their preference, but it's going to depend how you present that too. Do you want to be on Depakote where you gain 50 pounds, or Topamax where you lose 50 pounds? You have to be fair and balanced in the way you present a drug, but if you taking coexisting conditions into play is a good idea, looking at the AE profile and really discussing not just common potential side effects, but kind of unusual side effects, and then writing down in your note, please document that you did have this discussion with the patient is a good idea. I have always tried to use a review of systems, chatting with a patient, trying to figure out are there any comorbid conditions associated with migraine. And you know that most migraineurs are going to have comorbid conditions. So for example, depression, anxiety, bipolar disorder, irritable bowel, insomnia, epilepsy, fibromyalgia, Raynaud's. There's certain things that are going to run a little more often with a migraineur than with a non-migraineur. So if you did have someone, for example, who had Raynaud's, you might not put them just on a calcium channel blocker, but perhaps you put them on an AED and you needed something else. Calcium channel blocker, I'd pick that over a beta blocker, which could make the Raynaud's worse. Anxiety, an SSRI, maybe an AED. So like Depakote, which might give you a little mood stabilization. So I think that helps a little bit, because sometimes you can take the Class A drugs, but then you're going to go, what do I pick? So I think this is another way to look at it. So I have 10 minutes, and I want to talk about something completely different. I want to talk about migraine management in the office. And this is primarily, I want to do this for the residents. I think this is a useful way to start thinking about the way you're going to look at a new headache patient in your office or clinic. I think when you first take a history, and I know Dr. Mironova talked about migraine a few weeks ago or a couple months ago, try to anticipate the needs of your patients. So unless you send someone a copy of your history and physical, and I think we all should, I think it's really nice after your initial H&P to CC to the patient, because chances are they're not going to remember anything about what you told them to do, particularly if it's kind of complex in terms of what they're supposed to do, and it involves medication. If you don't do that, then write down for a mild to moderate headache, do this, for moderate to severe headache, do that. This is what you're going to use as rescue. And then as people come back, you might have 2 or 3 visits if it's not a simple migraine, to try to figure out an effective acute and preventative therapy. So reassess and modify as you go. You want to do initial therapy and match the treatment needs to the attack profile. Explain recurrence. A drug like Imitrex, the triptans, aren't going to stop the headache generator or modulator. We have this concept that people can get 1-day headache, 2-day headaches, 3-day headaches, and actually that's pretty true to form. So if you give them Imitrex and the headache goes away, it might come back the next day after the drug effect has worn off. It's okay to take another Imitrex. So they might be taking a triptan 3 days in a row. For recurrence, that's fine. Backup therapy, if their initial treatment fails, they might need something else. For a lot of people, it's going to be an injectable. Rescue therapy, there might be 1 or 2 times that you want to avoid the emergency room. If you trust them, if it's reasonable, you could do something that has an opiate in it. For example, a Dilaudid suppository, 3 milligrams, might keep them out of the emergency room. But education is, there's no substitute for that. Treating early and telling them why you're giving them what you do, and also try to figure out their triggers and avoid them, is, if you can pack that into your office visit, that would be great. I think the biggest single thing that helped acute therapy and migraine treatment was the concept of having an injectable versus an oral form to treat the headaches. So if you always need to ask someone how fast do you go from 0 to 60. When you start feeling the migraine, when do you get your peak pain? So if they say 30 minutes, you're not going to give them an oral therapy, because all our oral therapies take 1 to 2 hours to reach Cmax, the peak plasma concentration. You're probably going to go for an injectable. So sumatriptan injection, for example, reaches peak plasma concentration in 5 to 10 minutes. So that you want that. And we've got plenty of injectables now. We've got Toradol, you can teach IM in the office. So there's a lot of things there that I think you could do for these fast escalating folks. And that goes for early morning migraine too. If people wake up with a super headache, chances are it's been going on for a while. I think I would reach for the injectables there, not the tablets. The other thing too is this issue of gastroparesis. I think the longer a headache goes on, usually nausea builds up, and there is some evidence from GI studies that have been done that the worse the migraine is, the gut just stops. So you're not really absorbing very much either by that point. I bring in people who need urgent care because I don't want to send them to the emergency room. It's unpleasant, it's expensive, the lights are too bright. On the other hand, I don't have exam rooms, and if you bring someone in for urgent care, they're going to be there for 2 hours minimum. So that's why try to get everything pre-thought in the beginning. But if they have to come in, you're going to worry about what you give them. You can't give them sedating drugs. Let's say you're taking care of an MA in surgery. She comes in. You can give her a shot, but you're going to have to give her Toradol and Zofran and DHE. You're going to have to give her non-sedating drugs because unless she's got someone who could give her a ride. You're going to need to have the patient there enough to observe them, especially if you're giving them a new drug, and you've got to have staff there. So we'll give people injections, but they have to call before 3:30, or there's going to be no one there. Sometimes, if you can assess severity of symptoms over the phone, we can't do IV most of the time, so then they might as well just go to the ER if you need rehydration, or you need to check them for potential electrolyte imbalance if they've been vomiting a lot. You also need to be aware of what they've taken, so you have to take a good drug history and know what the maximum daily doses are of your medications. Combination approach is what we do in the clinic. So if you have nurses where you can do sub-Q or IM, dopamine antagonist if sedation isn't an issue. If it is, use Zofran or ondansetron. And then use either sumatriptan, which you can use subcutaneously, or DHE45, which you can do IM or sub-Q. And sometimes we'll just add on ketorolac 60 milligrams IM. Neuroleptics are underused and underappreciated. They're cheap, they've been around for a long time. There's a lot of different ones that I've listed here. Unfortunately, their side effects can be severe: sedation, drowsiness, EPS, and sometimes you can get by that with pre-treating with Benadryl. I don't want to talk about this, but it's in my slides, which I hope will be up in slide iCloud for neurology. So I want to show you 2 slides that I took from a talk I did at the American Academy of Neurology last year. And what I've done is go over a lot of data of placebo-controlled blinded trials and looked at this in terms of different drugs used in an urgent care or an ED setting. And these are percent of patients with pain relief. Now remember, pain relief is going from moderate to severe pain to mild or no pain. And if you look at the percent of patients with pain relief, you can see that the best drug we've got in the emergency setting is droperidol. Unfortunately, that is a black box warning and you need an EKG, unless some of the nurses feel they know that drug very well. They don't always do the EKG, but it's required now. Followed by sumatriptan, prochlorperazine, metoclopramide, IV. you can see a couple of things. The dopamine antagonists are way up there. And also, if you look at metoclopramide IV, you get 70% of patients with pain relief. If you look at the same drug given IM, it's 45%. So how fast you deliver the drug is also really important. And meperidine has some efficacy, but it's just a little over half of your patients. Yeah?
Do you use it before or after?
Before and after. Yeah, and then you'll just have it, which is nice. These are percent patients with pain freedom, so that's going from moderate to severe to no pain. That's your strictest criteria. And again, droperidol was number 1. But interestingly enough, droperidol is not number 1 here, but number 1 is a race between 2 other dopamine antagonists, chlorpyrrazine and chlorpromazine. And I think we underuse chlorpromazine, but there's reasons for that. Again, many times what you can do is just pre-treat these patients with Benadryl, and you might be able to get by that. Metoclopramide IV is once again better than metoclopramide IM, and ketorolac IM was sadly lacking, but in this case, meperidine was a little bit better. So, in summary, prochlorperazine and metoclopramide are the most frequently studied medications, and their efficacy was always superior to placebo. Triptans and DHE were equivalent to the dopamine antagonists in pain relief. Opioids, a little bit better than placebo, and I think Dr. Mironova mentioned this in her talk, that steroid use, for example, dexamethasone, can decrease headache recurrence after discharge. So they looked at patients and how often they came back, and if they did get dexamethasone as part of it, they were unlikely to come back for recurrence. So based on weighted averages of the percent pain relief, I recommend the combination of either droperidol or prochlorperazine plus sumatriptan or DHE and ketorolac or dexamethasone. Based on the weighted averages of pain freedom, prochlorperazine or chlorpromazine IV with either meperidine, sumatriptan, or magnesium IV. And IV is the preferred route of administration. Recurrence can be decreased with the dexamethasone. Thanks. I have -1 minute for a question. Yes.
I'm surprised you and many other headache experts brush past the use of IV Depakote. And I've had excellent success when I use it in the way that I treat status epilepticus. High dose given rapidly. And I have seen many very severe acute presentation of a chronic headache handled beautifully within 15 to 20 minutes.
Yeah. We do use it, but it's just 500 milligrams of IV, and you can do it really fast. It's just doesn't seem to be as effective as we'd like it to be. A lot of people do use it. So
when I have done it, it's 1,500 milligrams at 200 milligrams per minute.
Mm-hmm.
And that's the way we would treat status. The idea being you're delivering your drug promptly to the brain.
Mm-hmm.
It seems better than 32% of the people getting relief.
Thanks.
Sylvia, thank you. That was a great overview. The very last slide, or near the last slide, discussed your approach, which is to use a combination of therapies.
Mm-hmm.
Have they been studied? Have people? I mean, I'm very inclined to focus on what your successful strategies have been, rather than to just take an academic approach and look for studies with statistical significance. So obviously you believe in the combination approach as opposed to just using one of these drugs by itself.
Mm-hmm. Yeah, but I was really happy to see that what works in the clinic has also been backed up by evidence-based therapies. So we started using that. I've been doing that for 20 years because it seemed to work better. And I didn't always have access. I mean, the dopamine antagonists are really the hardest drugs to use because you can get a lot of skin sloughing, and I just don't have the IV capabilities. There's some really kind of neat stuff coming down the pike that are going to be devices. One of them you're going to see probably this spring is a drug called Levodex. It's going to be an inhaled form of dihydroergotamine. And it's not that. It's not the dihydroergotamine that's so exciting, but it's this turbohaler where just exerting a little negative pressure just takes these particles and just makes them into very tiny particles that are very rapidly absorbed through the lung. And one of the things they're working on is a compazine delivery on that. So if that would be great if they can do that. I mean, obviously and it's okay for the lungs. I mean, those tests are grueling, but I think it has passed. So we have done that, and I think one way to think about why to use combination therapy is, you're looking at you're blocking different potential mechanisms of migraine in the brain. I think everybody understands blocking the 5-HT1B and 1D receptors. But you also have inflammation going on, and so it makes sense then to have an NSAID. And there's a co-activation of the parasympathetic nuclei as well. So I think when you use all these together, we don't know if that's why they're working, but we know the theory, and we know that if you do this kind of mixing, that it works. And so it was nice to see the evidence-based. Or maybe I just like doing that because I used to be a pharmacist and I'm really comfortable with mixing and matching drugs.
So maybe I misunderstood. Have they tested these combined therapies against single therapy?
No.
Okay, that's it. I didn't think so. I thought that this was something that came out of your experience. And I wondered how you'd feel about doing them in a somewhat sequential fashion. In other words, let's say that you have somebody who's just a terrific responder. You would know this first time you're treating this patient with a severe headache in the emergency room. This person happens to be a terrific responder to droperidol. Boom, headache's gone. Would you still feel inclined to add something, or would you?
No, not if you have that history.
Well, no, there wouldn't be a history. I'm just talking about, you've never seen it before. Would you think about just trying one, waiting 30 minutes or whatever, and
yeah, and you know where that we do have some of that data, which I didn't show. We have the data because D2 receptor antagonists are used in isolation in many emergency rooms here in Canada, and it's probably one of the first drugs that we reach for in the pediatric ER population as well. So that's true. You kind of have to counterbalance that with the fact that if you don't treat a headache within 1 hour of onset, the chances that people are pain-free are less than 10%. But no, I totally agree with you there.
This question from Harmony.
Okay. Question is, you mentioned chronic migraine criteria including migraine without aura. Is migraine with aura specifically excluded? It is excluded, and I think we just don't have enough information on migraine with aura. I think that many of these people will have migraine with aura and without aura, so I wouldn't make a specific inclusion that they don't have chronic migraine, but it does specifically say without aura. Second one, many medications have headaches listed as a potential complication. How often do you identify such a medication as the cause of the headache, namely with the headache going away once the offending medication is stopped?
it's a trick question.
Yeah, it sounds like a trick question.
I think you're asking how often do I see headache as a side effect of a new medication? I think that's another way to say it. And everyone who has a headache from a medication will look up and find that headache is always a side effect, but I rarely see that. I would say that of common medications we may see, for example, the SSRIs have about a 10% low-grade headache side effect with low-grade nausea, things like that. But it's really not very often.
Thank you, Sylvia, very much.
Thank you.